Okay. Alright, guys. Welcome to our unknown session. So, this unknown session is all neuropath cases, and Dr. Dockstader is going to run you through some fun stuff. You didn't know that? Alright, Erica, all yours.
Okay, so this is the first case. Can we see a low mag?
Yeah.
One lower. Okay, so what are we seeing here? Does anyone want to describe what we're seeing?
We have a very hypercellular specimen in the brain. I can't say exactly where based on what we're seeing yet. There appear to be an abundance of smaller, possibly inflammatory cells, and I think I can pick out some atypia with some larger hyperchromatic nuclei scattered throughout. While there are some lighter, pinker areas, I wouldn't go as far as necrosis yet. I'd keep looking, but so yeah, that looks like inflammation, plenty of lymphs in there, some histiocytes.
Very good. So we see a lot of histiocytes and a lot of lymphocytes. What about those atypical cells you were seeing? Do you see those on high magnification?
Not so much in this field. I think in a field that we went by earlier on a slightly higher magnification, there might be one in the upper right of that field. A couple of slightly more atypical cells in there.
Alright. Okay. So can we go one lower?
Yeah. Is the condenser not right?
Its condenser's not right. Yeah. Can you flip it?
That's about the best I can get it. Let's see. So this, and then for the condenser, I can make it like this.
Slightly better.
Okay.
So do you think this is an inflammatory lesion, or do you think this is neoplastic?
I'm leaning neoplastic at the moment, partly because this is an unknown session. But this could well be inflammatory. With reactive atypia is still in my differential.
Alright, Aaron, there's a clue in this field. There's a clue to a very specific diagnosis in this field.
Very specific.
Is there a fungus?
The red granules.
Yeah.
Go to the black dots.
Yep.
Can you find the black dots?
Yep. So what could that be? Look, there's even necrosis.
Necrosis.
What could that be? So we're dealing with all this inflammation and necrosis, and here are the famous black dots.
Go up a little. Up a little.
Wow, we almost dotted right over the thing.
This is a cytology dot. Cytology dotting skills.
Okay, Aaron, here's your board question.
Very
Top-
good.
Toxo what? Toxocara?
Toxoplasma.
Ah, very good. How do we know? Yes. That's right. How do we know? So what is the morphologic feature of it? You know? Like how do you know it's not some other kind of organism? Erica, you want to tell them like the basic features of?
Yeah, so this is the encysted form of toxoplasmosis. So you get these somewhat pretty big cysts with these little bluish kind of granule looking things inside of them. So this is characteristic of toxo infection, and the inflammatory reaction that we see is very characteristic of toxoplasmosis. And it can be worrisome looking because it's very cellular. There are areas of necrosis, but you don't want to mistake this for a neoplasm. I've seen toxoplasmosis called high-grade glioma on frozen section because it's sometimes if it's sent as brain mass, you're not necessarily thinking of infection. But if you see a lot of lymphocytes and histiocytes, you should really think maybe this is something infectious in nature. The encysted form, you don't always see that. Sometimes you see the free tissue form of the tachyzoids. That can be very hard to see because there's all this inflammatory stuff going on. There is an immunostain that's available that can help in cases in which you don't see this.
Josephine, how are we doing for time?
5 minutes.
5 minutes done? Okay, you want to give them a take-home message for this case?
Take-home message, if you see a lot of lymphocytes and histiocytes, back off of thinning neoplasm, even if you see necrosis.
Yes. Okay, great. Next case, let's pick on Ellie for this one.
So
You want me to keep it at low mag or
you can keep it here.
here?
Yeah.
I see a population of small round blue cells,
Mm-hmm.
maybe with some molding. They're centered around vessels.
Sure, I'll just show you a little bit of the rest of it, and then I'll take you to high mag. Okay, Ellie, fair?
Do you think this is benign or malignant?
Malignant.
Okay, why? So what about this? Can we immediately say this is something malignant?
Necrosis. It's
There's-
just destroying the wall structure.
Mhm. The cells are pretty big, right?
They don't look like gland lymphocytes, and I mean, if they're just small round blue cells, then it's going to be, and not lymphocytes, it's going to be something bad.
So if this is something bad in the brain, what does it remind you of? What do you think it could be?
Lymphoma cells.
Lymphoma.
This reaction around the vessels is actually really typical of a CNS lymphoma or high-grade lymphoma in the brain. You get this perivascular cuffing like this. So this is an example of lymphocytes in the brain, possibly some necrosis, but this is malignant. And when you look at it, you can tell right away this is something malignant because it's high-grade. So lymphomas in the brain are generally diffuse large B-cell lymphomas. They're high-grade lymphomas. If you can see this perivascular packing of these cells around the vessels, that's pretty characteristic and should make you think of lymphoma.
Are they usually like primary CNS lymphomas, or are they usually brain involvement from a systemic lymphoma?
Actually, they're usually primary CNS lymphomas, and the absence of a systemic lymphoma is how you can sort of suggest that this is a primary CNS lymphoma. In this particular case, this patient has the systemic non-Hodgkin lymphoma, so this is sort of secondary involvement of the brain by a systemic lymphoma.
Okay, great job. The take-home message?
Take-home message: if you see a malignant tumor in the brain, that could be lymphoma. Check for this sort of perivascular cuffing. It's classic.
Yes. I would also say, at frozen section, or if you're faced with a quick diagnosis, don't always jump to a glial tumor, because that's what you naturally think, right? Oh, it's a brain frozen, there must be a glial thing. So you guys did great on this.
Yeah.
All right. Let's see. Let's do Dan. Dan, you want to take this?
Sure. So from low power, it kind of looks like it's almost biphasic. Like some of it looks a little bit more edematous over here, and then it's a little bit more solid in areas. I think I saw some Rosenthal fibers from low power somewhere
Wow.
at the edge. And then it's got a lot of these kind of vessels over in the more edematous area.
Rosenthal fibers from low power?
You were at higher power.
That is a good eye, man. That is a great eye. So tell us what Rosenthal fibers are, Dan.
I think it's like just kind of deposited GFAP that kind of like crystallizes. It's these like really eosinophilic kind of worm-like things. You see generally low-grade gliomas. It's not really specific.
How many of you have seen a Rosenthal fiber before? Oh, quite a lot of you. I thought you'd be excited to see this.
So does a Rosenthal fiber mean that you're in a tumor?
No, you can see it like in reactive gliosis or Alexander's disease can give you like diffuse Rosenthal fibers too.
Yeah, so it doesn't necessarily mean, you can see them in a gliotic reaction around, adjacent to a lesion.
Is there like a standard differential diagnosis for what you should be thinking when you see lots of Rosenthal fibers?
The first thing I would think of is pilocytic astrocytoma,
Mm-hmm.
because they occur quite commonly in pilocytic astrocytomas.
Mm-hmm.
Any kind of low grade, grade 1, non-infiltrative glioma. So if you see Rosenthal fibers in a glial tumor, you should consider a low grade, non-infiltrating glioma.
So this biphasic thing that he mentioned at LOMAC, what's the significance there?
You can see that in, that's a feature of pilocytic
I
astrocytomas.
see.
So loose glial tissue,
Mhm.
and then areas where it's more dense.
I see. And then,
And check out the vessels.
yeah, this stuff.
So there's a perivascular chronic inflammatory infiltrate. But not malignant, like in the last case. Clearly these are
Smaller.
small mature lymphocytes.
So then, yeah.
You know, just looking at this case, you think, okay, a pilocytic astrocytoma.
Mhm. So where are the neoplastic cells? What is actually neoplastic here?
So
Those-
all of these little glial cells are,
Very bland looking, isn't it?
yeah, very bland.
You almost, at least to the untrained eye like me, I'm like, where is this? What is the tumor
Yeah,
here?
they're very bland, not a lot of mitotic activity.
Yeah.
But this isn't a pilocytic astrocytoma.
Oh, it isn't. Okay.
Mm.
Okay. Here's another great example of this classic perivascular. So should I be showing something else?
There are some clusters of slightly larger cells.
In the pink areas or in the
Just scattered throughout.
scattered throughout? Okay. So why is that important? Why are we looking for these clusters of big cells?
Because in a ganglioglioma,
Mhm.
you can get, the glial areas can look very much like a pilocytic astrocytoma.
I see.
But the tumor contains these clusters of abnormal neurons or ganglion cells. They can be binucleated. So these two entities are often in the differential diagnosis of one another. On imaging, they can both have a cyst mural nodule configuration. Pilocytic astrocytoma, you can see those ganglion cells or neurons kind of entrapped at the periphery. But within the tumor in clusters, we're not finding them
Yeah.
yet.
Okay. So let's assume that this is there are a few ganglion cells. Can a pilocytic astrocytoma have like entrapped ganglion cells inside it?
Yes.
So how do you tell that? Like, how do we?
In
Figure it out.
ganglioglioma, they're supposed to be morphologically abnormal.
I
So
see.
they're more enlarged, they're kind of clustered together, they can be binucleated.
Mhm. Okay. So final diagnosis in this case?
It's a ganglioglioma.
Okay.
You
So
can see this perivascular chronic inflammatory infiltrate in that
Yeah.
tumor.
my bad for not finding the ganglion
I
cells.
should have
but
marked them, sorry.
But let's assume that there are ganglion cells here. Questions, Dan? Does that make sense?
Yeah.
Everybody else, does that make sense? Will you remember what a Rosenthal fiber looks like? Yes.
Are they EGBs?
Yeah, they're also eosinophilic granular bodies.
Which ones? Can you point out one?
See
Like the glob of eosinophilic granular
to the
body.
left?
That?
Yeah, like that.
Eosinophilic granular body.
Mm-hmm.
Oh, it's 5 minutes.
Okay, 5 minutes. All right. So this is a nice case. Any take-home message from this one?
If you see Rosenthal fibers within a glioma, consider a low grade, grade 1 tumor that's non-infiltrating.
Okie dokie. All right. Let's do Imad.
Mhm.
Let's give this case to you. Okay. Low-mag.
This is good.
The same kind of biphasic look. We have areas that could look dense, the other areas look loose, microcystic kind of appearing. The nuclei for the most part are small, bland looking. I thought I saw some cells that look larger or like more hyperchromatic, mature. especially in the dense areas.
Can I show the dense area
Some,
first? Yeah.
again, some Rosenthal fibers here.
Yeah. Everybody okay with that? The Rosenthal fibers? Okay. And then this is.
So I guess this is, we're gonna have the same differential as the previous case. So if we didn't find a ganglion cyst, this might be like a pilocytic astrocytoma.
Yes, very good.
All
How about
right.
those, there was some atypia?
Yep.
Did we find some of
Uh,
the darker, slightly larger cells?
like in here, like these,
Yeah.
maybe that big guy there.
That could be an entrapped neuron, hard to tell.
Okay.
But pilocytic astrocytomas can have degenerative type atypia, where you get kind of enlarged nuclei that kind of look a little smudgy and dark. And they can be quite big, and sometimes on frozen section you see these big, like, atypical looking cells, but there's generally no mitotic activity. These are otherwise very bland, and this is an example of.
So can I ask a question? You get similar stuff in the wall of craniopharyngiomas too, right?
Like
Rosenthal fibers.
yeah,
and-
reactive glial
Yeah.
tissue.
So the stuff that's happening on the top left of this field with the is that in the tumor or in the wall of the tumor? Like is that tumor too?
Yeah, that's
That is
tumor
tumor.
too. It's very kind of disorganized looking.
I see.
It's also, that's the dense part of the pilocytic astrocytoma. So it's a biphasic tumor. You get dense areas and loose areas.
I see. And in the loose areas, what is it that really like clinches the diagnosis of pilocytic? Like what
You
they
can,
what
in the
should
loose
they be?
areas, you can see more like the biphasic process, or the bipolar processes.
Mhm.
So if you pick out, one of these very bland cells, you can see the fibrillar process is extending from either side of the nucleus. So if you're looking for that feature in these areas, you can see that the best.
Josephine, how are we doing for time?
Oh, good.
We're good?
Yeah.
So clinically about pilocytic, what should we know? Like what is the important thing about this lesion?
In kids, they're most common in the posterior fossa. On MRI, they can look like a cyst with a mural nodule. They have an excellent prognosis when completely resected.
Yeah.
They can occur in other locations too. They can be in the hemisphere of the optic nerve.
These little microcysts are also pretty characteristic, right? These almost degenerated, like you might get in a ganglion cyst of the soft tissue. Like it just kind of breaks down and
Yeah, and those
Yeah.
kind of looser
loose in
glial
those areas.
areas.
Yeah, classic. This is very important for the boards. They ask you because you're supposed to know like classic tumors like this. Backward.
Yeah.
Just like this area corresponds to the intramural nodule on imaging?
I think just this whole tumor, even the loose areas, like this would be the solid part, the mural nodule part. And the cystic part, we probably wouldn't even see much of that at all.
All right, 2 tumors with Rosenthal fibers. We'll move on?
Yeah.
Okay. Who's gonna do this? Any volunteers? Frida, you wanna do this?
Oh yeah. So here we have a tissue that's more doesn't have any microcysts. It has this sort of jigsaw pattern
Yeah. Okay, let me show you a little one higher mag.
and seems to be like they're composed of vessels.
Yeah.
Yes. And we have this glial matrix outside the vessels. Could be some.
It's pretty much the same throughout, right? Is there any
Yeah.
particular area
No,
that's any
this is-
different?
This
Okay,
is
so I'm
very
gonna
different.
bring it to one spot and leave it there, and then we can talk about the case.
So is your impression, Frito, that this is something neoplastic?
Probably. I'm not sure.
How about those spindly cells? Do they look out like overtly malignant?
No.
They're pretty bland, right?
Bland.
Very bland.
What a great word bland is. It lets you say, like, I don't think this is malignant without actually saying that it's not malignant. Bland.
And the tissue in between, you can see there are some neurons throughout in there. So this is a very odd looking lesion, right? I remember when I first saw this case, I had no idea what this was. it's a very rare. And this lesion was sent as a tumor in a 2-year-old that was having seizures. So again, we have some cortical-looking brain parenchyma with this kind
This,
of,
right?
yeah, that's a neuron there, and then
one
this spindly, sort of serpiginous-looking
This stuff.
proliferation associated with blood vessels. So this is actually a really rare thing called Meningioangiomatosis. It's a hamartomatous lesion. It is a cause of seizures, and we worked up this case at the time from several years ago, and these spindly cells didn't really stain with anything. We did markers for meningothelial differentiation. We did like EMA, PR. Everything was negative. In some cases, they can look more meningeal. That's why it's meningioangiomatosis. They can look like meningothelial cells, but here they just look like kind of fibroblastic.
So why is it called angiomatosis? Is it a diffuse lesion? Is that why, or is it a localized thing that they can resect?
It's a localized thing that they can resect. I think the angio comes from the blood vessels that are associated with these spindly cells.
I see. And the neurons and all that is entrapped brain, or is it part of the lesion?
It's like entrapped brain.
It's entrapped
It's in a
brain.
hamartomatous lesion.
Oh, I see.
Yeah.
So good prognosis. Once you take it out, it's. Do the seizures
I
go
don't
away?
know if they're, if it's not completely resected. I think it would depend on the size of the lesion and how much of it they can get out.
Anybody seen a meningioangiomatosis before?
No.
No.
All right. It's okay to put a zebra in a case like in a thing like this once in a while, right? You'll see a zebra and then
Now
you'll see
you've
lots
seen
of.
one.
Yeah. All right. How are we doing for time, Josephine?
Great.
Okay, great. So I'm gonna back off and let's see. Atsuko, you wanna do this?
Sure.
Okay, so I'll just show you very low max scan around. This is a good field to show, right? This thing.
Lung.
Lung.
Is it lung?
It looks like lung, right? No, it's no pleura and no lung. Lung-like. But actually, that's a good thing to talk about here because for you guys, it's good to recognize what this might be if somebody says this is from the brain, and you see that tissue. Can anybody help Atsuko out? What could that be?
Dura?
What's that?
Like the meninges?
Yes. Dura, right? That's what you said.
Dura.
Yeah. So Atsuko, that's what it is. Dura. Is that right, Erika? That's all dura, right?
Yeah.
So what do you call a lesion like that? That's right next to the dura. There's like a
It could
CNS.
be the outside of the brain. I mean, it's not from the. It could be arising from the dura.
Yeah.
It's arising from the.
Or abutting the dura, right? Either it's either it's growing from the brain into the dura or it's arising from the dura and growing. Okay, fair. And want to see the cells now? So the dura is right next to it, and the lesion looks like.
There's a proliferation of spindle cells, and it has a eosinophilic cytoplasm, and also it has some kind. It's not. Do you call it inclusion?
Yeah, pretty cool, isn't it? Like these? Are they inclusions or whatever they are? They're pretty cool.
It doesn't look like a sum of a body
Does not. Why not?
because it doesn't have the characteristics of the sum of a body.
Yes, they're not purple, right? They're pink.
No,
And they're not concentrically laminated. They're
maybe
just.
there's some secretion,
Oh, good.
and this spindle cells is going in the organized
Pattern.
pattern.
Yes,
so it's
yes.
kind of going everywhere,
Very good.
and I think this is meningioma.
Okay, very
And
good.
I think it's some type of the meningioma. It's secreting type. I don't know what the
Wow.
type of
What
the
year are you at Atsuko? First year?
second year.
Second year? Okay. We'll promote you to third year on the basis of that. That's very good, right? Is she right?
She is absolutely correct. Yes,
Okay.
this is the secretory meningioma.
So what can we learn about this case? Erika?
So
Like what-
these things are called pseudo-Psammoma bodies. They're these intracytoplasmic inclusions. They They stain with PAS and CEA. These are grade 1 meningiomas. They otherwise, look like a typical meningioma. They can have clinically a lot of surrounding edema that's been reported in these cases.
So does it make a difference whether it's a garden variety meningioma or secretory? Like, does the fact that it's secretory change the grade automatically or no?
No, this is grade 1.
Oh, great. Grade 1 by definition.
Yeah.
I see.
Unless you were to find other features like brain invasion or mitotic activity, but unlikely.
So other than the brain edema kind of correlation, there's no other.
No bad prognostic significance.
Okay. Questions, guys? We doing okay, Josephine?
Yes.
Okay, let's move on. All right. Who's gonna take this? Gabriel, you want to take this? You want to do that?
Okay. Just checking it's this Gabriel.
Yeah. Yep. All right. Let me see. This is I'll just show you Lomax so you know that I'm not tricking you or anything. So this is all about the same looking, and then I'll show you Hymax.
Okay, so I think we have an infiltrative process. It's kind of basophilic, spindle cells, kind of going in these intersecting fascicles.
Yeah.
They're pretty atypical.
Yes. So bland would not be the right term here, right? It's not really. I mean, you could say it's not overtly. It's not like an undifferentiated pleomorphic sarcoma, but it's atypical, isn't it?
Yes.
What is in this?
Figure.
Yeah. So now you have a mitotic figure. But you're right that it's a spindle cell neoplasm. Everybody with him so far, right? Spindle cell neoplasm. There is some atypia. Is Gabriel, when you see a spindle cell neoplasm in a brain, let's say you go for a neurofrozen and somebody says spindle cell neoplasm, what pops into your head right away for a brain frozen?
Oh gosh. Meningioma.
Yeah. And one more thing pops into my head.
Sarcomatoid glioblastoma.
Oh wow. But you know what I think? I'm like, is it in the CP angle? Right? That's what I think. I'm like, is it dura based? It's meningioma. Is it CP angle? It's schwannoma. Like that, I think like a simple garden variety pathology. And then, but
So
you're
this
right.
is in the hemisphere.
This is in the hemisphere, and then it makes it a little tricky, right? Erica, do I need to show anything more, or do I have enough?
Yeah, if you could go to Lomax.
Lomax. Okay.
Let's look around a little bit. Like this area here. See that bottom area? Doesn't that look different than the spindly, malignant looking area? So if you just saw that bottom pink area, what would you be thinking? Does it look glial?
Yeah.
It kind of has a glial background, right? Those atypical cells. So this looks like a glioblastoma.
So it has all the other stuff, the vascular endothelial
Yeah, in
proliferation
theory, this
and all
is
that.
malignant. I'm sure
Yeah.
there's necrosis somewhere.
Yes.
And mitotic activity. Of course, you'd want to make sure this is a high grade lesion.
Yeah.
See that down there? There's like sort of a looser looking
This?
area. Yeah.
Yeah.
So this is a Gliosarcoma.
Yeah.
It's kind of a subtype of glioblastoma.
So Gabe was right. Yeah.
Yes.
Amazing. These
Yeah.
guys are super smart.
I know, you guys are doing awesome. So the interesting thing about these tumors, they usually have a component that you can recognize as glioblastoma, even if most of it looks like just a bad sarcoma. The GFAP stain will stain the glioblastoma areas and it'll be negative in the sarcoma areas. And a reticulin stain will there will be reticulin fibers in the sarcomatous area and you don't see that in the glioblastoma. So those two stains kind of mirror each other. So if I get a case like that, I usually will do like GFAP and a reticulin stain just to sort of highlight that almost biphasic nature of the tumor. These most often occur de novo like this, But the gliosarc areas can occur in a glioblastoma that's been irradiated previously. So this could be like a recurrence of a glioblastoma after irradiation. And these are IDH negative, so IDH wild type tumors.
Okay. All right. Next case. Jasmine, you want to take this one?
Okay.
Minshan, right? That's how we pronounce? Okay. All right. So let's do. So this is the one part of the slide, and this is another part of the slide. I'll show you higher mags of both. Just show you just an overall, like give you a feeling. Okay, got a feeling for it? And now let's go to high mag. And then this is the.
Here, this area looks like benign brain parenchyma.
Okay, great. So we don't need to look at that, right? Who cares about benign brain? All right, and then what's going on here?
It's kind of infiltrating from this. You see a little bit infiltrating to the normal brain, which means this tumor is not well circumscribed.
Yes, great observation.
And there is like a papillary structure forming.
Yes. Papillary. So this cannot be NIFP if you have good papillary. All right, Jasmine. Or a what? Or a follicular variant. All right. All right, Jasmine. So here's a higher mag. You want me to move around, or is that good?
It's okay.
Okay.
So I feel the cell is kind of epithelioid, has a prominent nucleoli with pink eosinophilic cytoplasma.
Yes.
And also it's kind of surrounding the vessel. Oh, it's like a papillae with no vessel,
Yeah.
microvessel, vascular core inside.
Perfect. Yeah.
So, well, it could be metastatic tumor,
Mm-hmm.
or it can be primary
Right.
brain tumor.
You've narrowed it down. What else? What else, Jasmine? Give me commit to 2 or 3 things. Let's make it. Now you have to guess. It's unfair because clearly you would do immunohistochemistry or nothing like this, right? But what would you guess from this? What would be your differential that you would then try to pursue with immunohistochemistry?
Melanoma.
Okay. So melanoma is your number 1 or 2 or 3? What is it? Okay, that's fair. And anything in the differential besides melanoma, or could it be anything else? I mean, it's papillary, isn't it?
Papillary.
Is that characteristic of melanoma?
No.
Could be like a choroid plexus carcinoma.
Choroid plexus carcinoma. How about just a flat out carcinoma?
Yeah.
Right? Metastatic carcinoma from wherever, from the lung, from any site. So I would think of a carcinoma. So on the H&E, can you find anything that would help you, Jasmine, in like favoring one or the other?
Pigment.
Is there any?
Maybe it's just macrophage. Hemocydary. It's not. Really.
Yeah, so that's fair. You know, when you see the pigment, you go, oh, it could be a tumor that's bleeding, you know, and that's why there's that thing. Or that could be melanoma. Okay, that's very good. Erica, so how do we approach this? What should be, how do we go from here?
Yeah, so I mean, clearly it's malignant. It's pretty demarcated from the adjacent brain. So on low mag, you can see it's not infiltrating in the way that gliomas infiltrate diffusely into the surrounding brain. So right away you would think this is something metastatic. And I think her differential is spot on. With the pigment, you would consider melanoma, but the weird papillary architecture, you might think of carcinoma.
Yeah. So you'd work this up, right? And what stains would you do, Jasmine, to confirm it?
Yes, we look at the history first.
Huh? You look at the history, yes, for sure. And then maybe you might still want to confirm it, right? Yeah. And what would you do? What stains?
TTF1.
Uh-huh.
No, sun cracking for
Yeah.
any organ specific TPF1.
But to confirm your top suspicion, what would you do then?
PAX8.
No, for melanoma as well.
Melanoma.
Yeah.
Oh, yeah, for sure. S100, some scan.
Yes. HMB45, maybe Mark 1, right? Yeah. And what was the diagnosis here?
Metastatic melanoma.
Metastatic melanoma. Good. All right. We could not fool you. See, I thought people would see the papillary structures and say, oh, this is carcinoma. But no, Jasmine is good. So we could not fool her. All right. We'll fool you with something else. Okay. Who is Anurag? You want to take this?
Yes.
Okay. Let's see.
So there are some cystic areas, there are cellular areas, also hemorrhage. It's mostly looking glial tumor.
Unfair, really. I'm just showing you the low MAC, but I'm just trying to give you a feel for it. Actually, to be fair to you, Anurag, as I go, as I move around this slide, I totally have no idea what this was. So I'm as clueless as you are. But let's see. Okay, so here's the high MAC.
So what's this stuff for?
It's like calcification, microcalcifications.
Is this the right area, Erica? Should I go high MAC here?
Yeah, that's a good idea.
Just show him the cytology.
How about the nuclei? What do the nuclei look like?
They're round with open chromatin, some small nucleoli. Some of them have like a very nuclear halo.
Ectoplasmocytoma. Some of them.
Some look a little plasmacytoid. So nuclear halo or perinuclear halo, what are you getting at?
I was thinking of oligodendroglioma maybe.
Yeah, that's a very good thought with these rounded nuclei and this sort of, clear space around the nucleus. That's an artifact of formalin fixation that we see in oligo. What about the calcifications? Is there any significance to those? It's sort of a soft feature of oligodendroglioma. So sometimes you see calcification and a slow-growing tumor with a grade 2 oligo.
Yeah. So is that what it is?
That's what it is. There are some areas that show the vascular pattern.
Okay. So we can go to those. My sense from the oligodendroglioma thing is that from the time that we trained to now, like everything has changed. This used to be a thing that neuropathologists love to argue about, like whether something is oligo or oligoastro or pure astro. And now the molecular stuff has changed it, right? So how do we approach that? Like what markers do we do? What's considered definitional?
So oligodendrogliomas should be IDH1 mutated. So if you get a tumor that you suspect could be an oligo and the IDH1 immunostain is negative, you should kind of rethink your differential diagnosis. Now, I feel that the morphology in oligo is very difficult because it overlaps with many other tumors. It overlaps with dysembryoplastic neuroepithelial tumor. I mean, it can look like diffuse astrocytomas can have areas that look like this with more rounded nuclei. So, we do IDH1 in all of these cases. And also, if you're not entirely sure this is oligo, I wait for the 1P19Q fish to come back. And we've actually increased our runs of fish, so we run it a couple times a week, so we can get it quickly if we're holding the case for it. But I would hesitate to diagnose oligo if I have a case that's IDH negative and not 1P19Q code-deleted, just because the morphology does overlap with a lot of other tumors. And that being said, there's a subset of oligo in young kids that can be negative for IDH1 and 1P19Q, and those are very difficult to definitively pigeonhole.
I see. So for boards, is it fair to say that most oligos will be 1P19Q?
Yeah, code-deleted.
Code-deleted?
Yes, almost definitionally, like.
It's almost definitionally.
Yeah, and IDH mutated.
Okay. Any questions, guys? Any questions about oligo, morphology, all this 1p19q2q gobbledygook? Anything about that? Questions? No? Okay, great. Josephine, we okay for time? Alright, so let's go to the next. See as many cases as we can. Who wants to take this? Any volunteers? Who did I miss out so far?
Ahmad.
Yes, Ahmed, go for it.
So from low it looks very blue lesion with a communal type necrosis in the middle.
Yes.
So very basophilic, very high nuclear rate,
Yeah,
and very high NC ratio.
that's correct. And of course there's necrosis, right? So I don't want to show it. Show that again. I'll show you the lesion. Anything else about this? About the just the morphology of this lesion?
I mean, nuclear look. This has a vesicular type content.
Yeah, vesicular, isn't it? Yeah. What's up with that? Is that any kind of helpful feature? Alright, so let's say that's not a helpful feature and you're just trying to approach this lesion, right? You are the attending and you have to do your immunostains to figure this out. So what's your differential, Ahmed? What are you thinking?
Maybe some sort of embryonal type.
Embryonal, like a germ cell tumor?
No.
Or like a medulloblastoma?
Meningioma.
I see. Yeah, medulloblastoma, PNET. Yeah. I mean, it's a brain thing, it's a small blood blue cell tumor. That's a reasonable thought. Anything else?
Yeah, it could be a metastatic tumor, but
From like what kind of metastatic tumor?
small round blue cell.
Small round blue cell. So not a non-small cell carcinoma or that kind, right? What kind of tumor do you think that would look like this?
Ewing sarcoma.
Ewing sarcoma. Okay, so some kind of metastatic small round blue cell tumor. Can anybody guess based on this morphology what is it that is kind of a little bit of a clue in this morphology? Erica, is that a fair
I
question?
heard a whisper from behind.
Oh, we were just talking about the washed out nuclei
Yeah.
and the
Tell us.
Merkel.
Huh? What is that?
The Merkelish, Merkely.
The Merkel look. You know, when Erica, I don't know if you remember this. When we were residents, there was another one of our residents who said, once you see a Merkel cell carcinoma, you never forget it. Okay, so maybe that's overstating the case a little bit.
Yeah, but
Right?
there's something about this chromatin.
Yes, there's
right?
something about the washed out nature of the chromatin that should at least make you think about it. And if you think about it, maybe you will. So this is
This
Merkel
is
cell.
metastatic Merkel cell
Merkel cell
carcinoma to the
carcinoma.
brain.
And I think the point is that it can so mimic other small round blue cell tumors.
Yeah.
So unless you knew the history, this could be a difficult diagnosis. You could easily go down the wrong path in these. I think I recently showed you one that was like a differential of a lung small cell, right? So it can really fool you. But again, in many cases, I don't want to say most, but in many cases you already know the history from before, so all you need to do is confirm.
Confirm.
Yeah. Erica, what would you, like if you saw this right off the bat, what would you think? Like without any history?
I would think it's malignant, consider metastasis.
Is there anything
Possibly
that's
small
wrong?
cell.
Why is it not a medulloblastoma? Like what's wrong with it for
There's
a
no fibrillary
Uh-huh.
in the background. But you might think that. Actually, this is a posterior fossa tumor
Oh, I see.
in an older person.
Medullos are usually young people, right?
Usually, but they can occur in any
In
age.
older.
But yeah, usually they would be in a young person. But this just has like the cohesive
Okay.
look of a carcinoma.
Metastatic Merkel cell. Okay, let's go fast. Now we'll speed up, try to show them all the rest, okay? Alright, so I'm going to, instead of picking on anybody, we'll just show you quickly and have somebody take a guess at it. Anybody? Anything else I should show, Erica? Low mag, different areas?
So, glial or not glial?
Glial.
Glial. Low grade or high grade?
Low grade.
It's low grade. What are these funny looking blue areas?
Myxoid.
It's myxoid. It has sort of a pattern to it.
Myxopapillary.
It's a myxopapillary.
Yeah, very good. All right, very good, guys. Where do these things occur? Yes. Any take-home message about it?
These are benign. They occur in the spine. You'll see them on frozen section. Sometimes they recur if they're not incompletely resected.
Perfect. All right. Next case. Anybody can take a shot at it. I'm going to go to hi Mac. You guys are doing great. Show the pattern if I can. Is that a good area, Erica?
Yeah, it's a good area. Again, glial or not glial? Okay. We go back to the map. Actually, haven't E this case.
Oh, okay. All right.
So see those zones of glial tissue that without nuclei? See, there's a small vessel up at the top with a anucleate glial zone around it. You see that? And then there are these cells around it. So what is this? Close. It's an ependymoma, yeah. So this is also in the spinal cord, up further than the previous case.
All right. Okay, we'll let you go and we'll
Okay.
try to take the stab at the rest ourselves.
Okay.
Thank you.
Yeah, thank you.
All right, guys. Here's one for who's a first year that I haven't picked on yet? Anybody? Yeah. First year? Did I not pick on any first years yet?
I'll take it.
You know what? Yeah. Okay. What is this?
Well, I see calcification.
Yes.
It's kind of spindly.
Yes.
It's very spindly.
All right. Let's cut to the chase. What do you think it is? What are those purple things?
Psammoma body?
Yeah. So that's pretty much a clue to what this is, right?
Sure.
Yes.
I have no idea.
Think of spindle cell tumor in the brain. So let's say I told you it was dura based, then what would you think? It's coming out from the meninges?
Meningioma?
Yes, it actually has this pretty much the same morphology as the other case, just slightly spindlier. But the Psammoma bodies are really a great clue. And actually, if you step back, you just see how many there are in this. This is just like a classic Psammomatous meningioma. Everybody okay with that? All right, next case. Let's see. If I get it wrong, just correct me. All right, what is this lesion?
Maybe
That would actually be a good thought. I think I thought the same thing, and it might actually be correct. And you're actually seeing some hemorrhage in the surrounding brain, right? Yeah. This thing was actually called cavernous angioma. And you can see why, right? I mean, it's basically the same family of lesions. I think on an AVM, what you want is like a thicker feeder vessel, and then thinner vessels next to it, whereas this is all kind of like big vascular lesion.
And AVM has intervening brain tissue between the vessels.
Intervening brain tissue. Look, she's definitely absorbed her neuropath knowledge. Great tip, Josephine. All right, let's see. Let's see if we can get you with one more lesion. We're almost at the end. All right, guys. Let's see if you absorbed our tips. Anybody? Benign or malignant? Tough, huh? Tough. Okay. I'm going to give you guys 5 seconds to make a specific diagnosis. 1, 2, 3. Right? So once you know that morphology, see how powerful that is. It's just, you need to find the organism. And just think of the background lymphoplasmocytic infiltrate and remember this morphology for toxo. Everybody good with that?
Yep.
All right. 2 more cases and we're done. This one. All right. What is, let me just back up a little. That's really the region. And it has this inside it. Yes, Craniopharyngioma. Tell us the features quickly.
This keratinization.
Yeah, calcification and this kind of keratinization. If we were in the skin, what would you call this? What do you see it in the skin?
Epidermolysis.
No, like a pilometricoma. You know, the same kind of, the general principle is the same. That kind of ghost cells, wet keratin, calcification. But this look is very, very, very characteristic between the calcification and this. Alright, last case and I'm going to let you guys go. What is this? Even I don't know. Okay, so it's Dura based, right? And we've got something in here. Anyone? Papillary what? Yes, so I'm not sure of the exact variant. Unfortunately Erica is gone now. So but this is a meningioma variant. So just remember that, you know, if you see an epithelioid looking thing in the dura and you're tempted to call it malignant or say that it's a metastasis, step back and think, could this be a meningioma variant of some kind? So that's what this is. Alright guys, did you enjoy it?
Yeah.
Alright, thank you for coming.
Thank you.
Thank you.